Bismillah ar-Rahman ar-Rahim. We'll discuss a simple revision of the obstetrics and gynecology clinical rounds. The aim of this slideshow is to solidify the basic knowledge gained throughout the 3-month clinical rounds in obstetrics and gynecology in Mansour University Hospital, Mansoura, Egypt, in the form of multiple choice, cross-matching, and short essay questions and clinical case solving. This will cover the subjective of studying these subjects of case taking, anatomy, embryology, instruments, and models. The revision includes about 150 slides. I will divide them into two recordings. We start with obstetric case taking. First question: the term gravidity includes the following except all pregnancies terminated by delivery. Remember, we are asking about gravidity, not parity. All pregnancies terminated by abortion, hydatiform mole, ectopic pregnancies, pseudocyesis. The correct answer is yes, it is E. The next question: the term parity includes the following except full-term normal deliveries, preterm labors, pregnancies terminated before the 20th week of gestation, cesarean sections, stillbirth. The term parity includes all except those pregnancies that are terminated before the 20th week of gestation. So the correct answer is C. All the following conditions are considered difficult labor except deliveries of twins, venous delivery, cesarean delivery, breech delivery, delivery of a fetus presented by the face. We first mention the definition of difficult labor. Difficult labor is that vaginal delivery that is not fulfilling the criteria of normal labor, which are spontaneous expulsion of single living viable, let's say 37 weeks or more, fetus presented by its vertex through the natural birth canal within a reasonable time from 3 hours to 24 hours without any assistance except pitocin drip and episiotomy, and without complication to the fetus or the mother. This is the definition of normal labor. Any of these conditions are eliminated from the definition, it is a difficult labor. So the exception here is C. Cesarean delivery is not a vaginal delivery. The diagnosis of a woman with twin pregnancy and previous history of one vaginal delivery, one cesarean section, so there is 2 deliveries, 1 second trimester abortion, so there is 1 abortion, 3 pregnancies, 2 deliveries, and the current pregnancy is the 4th. So the diagnosis of this patient is 4th gravida, 2nd para. The answer is B. Fourth gravida, second bar. The patient is twin pregnancy, one vaginal, one cesarean, one second abortion, and one ectopic. We forget the ectopic, so the answer is B. Fifth gravida, second bar. The body mass index is calculated from the following formula: weight in kilogram over height in meters, weight in kilogram multiplied by the height in meters, weight in kilograms over the height in meters square, weight in grams, height in over the height in meter, weight in grams over the height in centimeter. So the correct answer is yes, weight in kilograms over divided by the height in meter square. So the answer is C. All the following are causes of uterus larger than the period of amenorrhea, except multi-fetal pregnancy, hydramnios, fetal macrosomia, intra-uterine growth restriction, uterine fibroid with pregnancy. So the exception here is the intra-uterine growth restriction. So the correct answer is D. The correct answer is D. All of the following are causes of the uterus smaller than the period of amenorrhea, except intra-uterine growth restriction, hydramnios, misabortion, miscalculation, the minority of hydatiform mole smaller than the period of amenorrhea. So the hydramnios is the exception. It is a cause of uterus larger than the period of amenorrhea. The answer is B. During the performance of fundal grip, the head is recognized by the following criteria, except small in size, hard in consistency, not tender, smooth in contour. Its movement is independent from the other body parts. The sentence E is called the head ballotment, and the correct answer is C. The head is tender on palpation. The breech is not tender on palpation. The answer is C. During the performance of fundal grip, the breech is recognized by the following, except bulky in size, the breech is bulky, soft in consistency, the breech is soft, not tender, the breech is not tender, irregular contour, the breech is irregular contour. Its movement is independent. No, there is no ballotment of the breech. There is no ballotment of the breech. So the exception and the correct answer is E. The four standard positions of the fetus are the following in sequence from the first to the fourth. The first position, the back is left and anterior. The second position, the back is right and anterior. The third position, the back is right and posterior. The fourth and last, the back is right and the back is left and posterior. So left anterior, right posterior, left posterior is the correct answer, and so the answer is C. The cephalic presentations include the following. We have 5 cephalic presentations. 3 of them due to the movement of the head on the atlanto-occipital joint, the antero-posterior movement, and the other two positions are due to the movement of the head laterally. So the cephalic presentations include vertex presentation, brow presentation, face presentation. The difference between these are the degree of flexion. The vertex is the head is fully flexed, brow is midway between flexion and extension. This is called multi-fetal attitude, and face, the head is fully extended. The other two across the lateral movement axis are the anterior parietal bone presentation and posterior parietal bone presentation, and these are the asynclitism. So we have 5 cephalic presentations: vertex, brow, face, and anterior parietal bone and posterior parietal bone presentations. How the fetal attitude affects the presentation? We mentioned this in the previous slide. This table will answer the question. When the head is fully flexed, the vertex is the presenting part, and the presentation is vertex, and the dominator is the occiput. When it is deflexed, the brow and the forehead or frontum is dominator. When it is fully extended, the face is the presentation, and the mentum or chin is the dominator. Slide test is the syncretism, and this is the confirmation of the knowledge about the positions of the head according to the fetal attitude, fetal head attitude. Mention the value of each of the obstetrical maneuvers. The first at the fundal level is to roughly know the gestational weeks. The second maneuver, which is the fundal grip, is to identify the fetal part that occupy the fundus uteri, whether it is the head, the breech, or nothing. Nothing is in transverse lie, and there is no fetal part occupy the fundus in transverse lie. The third maneuver is the umbilical grip, which aims to identify the direction of the fetal back, what's meant by position, fetal position, whether the back is to the left or right, anterior, lateral, or posterior. The next maneuver is the first pelvic grip, is to confirm what fetal part occupy the lower uterine segment, and also it may give an idea or a clue for fetal head engagement. The last maneuver is the second pelvic grip. It is done only in cephalic presentation to determine the fetal head attitude, whether flexed or extended, by trying to palpate the sensibut and the occiput. The occiput is identified by that bone in the direction of the back, determined by the previous umbilical grip. Another combined grip, which is a quick method to determine the fetal lie presentation and position in one grip. It is used by the experienced obstetricians. Define the dominator. Gives an example. Dominator is the bony landmark that characterizes the presenting part. The dominator was mentioned in the previous the slide 15 as follows. The vertex dominator is occiput, face dominator is a chin or mentum, brow dominator is a frontum or forehead, breech dominator is a sacrum, shoulder dominator is scapula, asynclitism dominator is parietal bone. So these are the bony landmarks of each presentation. Describe the technique of clinical pelvimetry. Clinical pelvimetry is to assess the pelvic capacity. The diagonal conjugate is measured by vaginal examination by middle and index finger inserted into the vagina, directing toward the sacral promontory. If the promontory of the sacrum is reached, the pelvis is smaller than normal, except if the examiner's fingers are extremely long, unordinarily long. In the ordinary hand, if the promontory is reached by the adequate examiner's hand, usually the pelvis is smaller than the normal. The normal diagonal conjugate is 12.5 centimeter. It is a rough measurement. We get an idea about the actual anatomical anteroposterior diameter by subtracting 1.5 centimeter from the measured diagonal conjugate. So if it is 12.5 centimeter or more, when we subtract 1.5 centimeter, so the anatomical anteroposterior diameter is 11 centimeter, and this is normal length of the anatomical anteroposterior diameter of the inlet. The pituitary diameter should be as wide as a fist, average fist for knuckles. The prominence of the ischial spines and the width of the subpubic angle should be assessed. The ischial spine should not be prominent on vaginal examination, not spiky, and the subpubic angle should admit 2 fingers easily, and so it is 90 degrees or more to identify this outlet as adequate outlet. And the next slide will gives the illustrations of the pelvimetry. This is the estimation of the diagonal conjugate. I try to get laser pointer. This is laser pointer. Yes. This is the diagonal conjugate estimation. This is the fetal head. This is the sacral promontory, and we get a mark here on examination and withdraw our hands and measure this distance from the tip of the middle finger to this landmark by a ruler and get the length. And this is how to estimate the pituitary diameter by the fist. Define engagement of the fetal presenting part. How to diagnose? Engagement of the fetal presenting part is the passage of the widest transverse diameter of the presenting part through the plane of the pelvic inlet. The pelvic inlet is the plane passing through these points from posterior to anterior. The sacral promontory, ala of the sacrum, sacroiliac joint, iliopectineal line, iliopectineal eminence, superior ramus of the pubis, and to the symphysis pubis and to the other side. This is the engagement. The widest transverse diameter of the head is biparietal diameter, which is 9.5 centimeter. The widest transverse diameter of the breech is the bitrochanteric diameter, which is 10 centimeters. Here we should remark that The biparietal diameter is the widest transverse diameter of all cephalic presentations. Any presenting part has two engaging diameters, the transverse diameter and the longitudinal or anterior diameter. The longitudinal diameter is different according to the attitude of the head. The transverse is fixed in all cephalic presentations. So it is the transverse diameter in vertex. It is a biparietal diameter is the transverse diameter in engaging diameter in vertex. It is the engaging diameter in brow. It is the engaged diameter in face. However, when there is lateral tilt of the head, the engaging transverse diameter is not the biparietal diameter. It is smaller, which is supraparietal diameter, which is 9 centimeters. We should remember this valuable information. Diagnosis of engagement may be performed by an abdominal method, which is by rule of fifths. If the head is filled, 3/5 of the head are filled abdominally or more, it is not engaged. If less than 2/5 of the head are filled abdominally, it is engaging or engaged. Another method for diagnosis is the delay station. We divide the pelvis into planes, starting from the plane of the ischial spine, which is the plane of the least pelvic dimensions. The ischial spine is at station 0. Above the ischial spine towards the pelvis is -1, -2, -3, -4, or and so. Below, lower than the ischial spine, +1, +2, +3, +4, +5. And the lowermost bony part of the presenting part, when it is at this level, we called it is engaged, not engaged. Engagement here, when the lowermost bony part of the head is filled below the level of the ischial spine. And a question erupts here. What are the most pathognomonic diagnostic test or sign for engagement? I will tell you this knowledge. The most accurate or pathognomonic sign for engagement for diagnosis of engagement is the obliteration of the retropubic space by the head. Obliteration, you cannot insinuate your fingers, examining fingers between the head and the symphysis pubis, and so there is a complete obliteration of the retropubic space. What are the indications of vaginal examination in an obstetric case? There are many indications of vaginal examination, and it is not a routine procedure. It is not a routine procedure. We can diagnose early pregnancy in absence of ultrasound by the criteria of pregnant uterus, which is globular soft. Diagnose of clinical types of abortion according to the condition of the cervix, whether it closed, opened, soft, the product conception are felt or not. Diagnosis of a cause of antepartum hemorrhage after exclusion of placenta previa, and what's called double setup examination. It is performed in rare conditions with all the preparations are prepared, or the requirements for the section are ready. Confirmation of suspect cases of rupture of membrane, premature rupture of fetal membranes. Transvaginal diagnostic procedures are another indication for vaginal examination in obstetrics. Assessment of the pelvic cavity as previously mentioned. Diagnosis and follow-up of normal labor by a diagnosis of cervical changes, cervical dilation, and station of the head, and the condition of membranes. Confirmation of fetal presentation by trying to identify the posterior fontanelle, the sagittal suture, and the anterior fontanelle, and the direction of these posterior fontanelle towards the right or left of the patient, and whether anterior, lateral, or posterior. We can identify the fetal presentation, fetal position by knowing the criteria of the fetal head, knowing the criteria of face, knowing the criteria of breech, and also knowing the criteria of the scapula and the ribs in transverse presentation, transverse lie, shoulder presentation. We shift to the gynecology case, gynecological case taking. The first question: give the definition of each of the following. Menarche. Menarche is the first menstruation of the female life. Usually in Egypt, menarche occurs at the age of 9 to 14 years. If menarche is delayed than 14 years without the presence of second sex characters, it is called a primary amenorrhea. If the secondary sex characters are present, however, the menarche, we should wait until 16 years. If the menarche is delayed after 16 years, with or without second sex characters, it is also called primary amenorrhea. So menarche is the first menstruation of the female's life. Cycle length. The cycle length is the length of time starting from the first day of the cycle to the first day of the next cycle. The normal cycle length ranges from 3 to 5 weeks or 21 to 35 days. Intermenstrual period, it is the period starting from the end of the flow, menstrual flow, to the first day of the next flow. From the end of the menstrual flow to the first day of the next flow, and so it is a blood-free zone. Menstrual flow is the period of menstrual shedding. It ranges normally from 2 to 7 days. Dysmenorrhea is painful menstruation that interferes with the lady's daily routine. Menstrual melamina is a painful menses but not interfering with the lady's daily routine. The second question is: mention the items of local gynecologic examination. Local gynecologic examination starts with vulvar inspection, vaginal palpation, bimanual examination, speculum examination, and these are sequential steps, except if cervical or vaginal cytology is recommended, vaginal palpation is replaced by speculum examination to facilitate obtaining the cytology specimen. The last is special clinical tests such as perectal examination, rectovaginal examination, stress test, and so on. And these are complementary steps, differs from one case to another and has special indications. However, and so the basic steps are the A, B, C, D. E, special clinical tests are done when indicated. Mention 3 clinical tests for diagnosis of urinary stress incontinence in female with genital descent. The first is Marshall test, Yusuf test for hidden incontinence, Poni's test, and last Marshall-Marchetti test, Hodge-Smith-Bessery test, Hodge-Linson test, and BAD test. Lastly, the Q-tip test to assess the bladder angle in cases of bladder angle mobilization. These tests are explained in a separate slideshow. Mention 3 clinical tests to diagnose rectovaginal fistula. Rectovaginal. The probe test, which is a small probe, is pushed through the vaginal orifice of the fistula and felt by rectal examination. Methyl blue test, methylene blue test, methylene blue instillation from the vaginal orifice can be seen in the rectum via proctoscope, and the Caris test, Follis catheter, 10 milliliter balloon is inserted onto the anal canal while the vagina is painted with concentrated solution of soap and water. The balloon is inflated with 10 milliliter saline and make the anus tight as the rectum is distended with air passed through the catheter. Its bubbles in the vagina locate the fistula. Mention 3 clinical tests to diagnose vesicovaginal fistula. Intravesical dye test. The urinary bladder is filled with diluted solution of methylene blue or indigo-carmine, but methylene blue is more preferred. Careful inspection of anterior vaginal wall and vaginal vault with same speaker in left lateral position for the colored urine passing into the vagina. 3 tampon tests of Moir. 3 vaginal tampons or cotton balls are placed one after another in the vagina. Bladder is filled with diluted methylene blue, and if the upper cotton pole is colored with methylene blue, this is a vesicovaginal fistula. A flat tire test. The patient is put in the knee chest position and the vagina is filled with water or saline. Intravesical installation of a carbon dioxide or air through urethral catheter. Localization of a small fistula is done by visualization of gas bubbles in the vagina. List the indications of rectal examination in gynecology. Rectal examination in gynecology is indicated in pelvic examination in inversion, is substitute CBV, and bimanual examination for evaluation of the uterus, adnexal or pelvic mass, diagnosis of parametrial infiltration cancer cervix, detection of mass in the cul-de-sac, diagnosis of rectal infiltration in gynecologic malignancy, differentiation between true and false rectocele, and diagnosis of rectovaginal fistula. List the indications of rectovaginal examination in gynecology. Evaluation of rectovaginal septum, such as in case of endometriosis, diagnosis of rectocele, which is called Malpass test, evaluation of the tone of the levator ani muscles in cases of prolapse preoperatively, diagnosis of rectovaginal fistula. List the indications of uterine sounding, measurement of the length of the cervical uterine canal, determination of direction of the uterus AVF or RVF, differentiation between the uterine inversion from submucous fibroid, differentiation submucous fibroid originating from the fundus to that originating from the cervix, determination of the relationship of the uterus to any pelvic mass, whether it is separable or not. In case of prolapse, to differentiate true prolapse from congenital elongation of the portion vaginalis of the cervix. Also, it diagnoses supravaginal elongation of the cervix in vaginouterine prolapse. Diagnosis of intra-uterine masses, submucous fibroids, uterine septum, bicornate uterus. This is found are only suggested, but should require further investigation for confirmation of diagnosis. Diagnosis of intrauterine foreign bodies such as IUD, and probe tests of variability for cases of cancer cervix. It's all the tests which was called Kropak test, and Click test for diagnosis of zygovaginal and rectovaginal urethrovaginal fistulas. How to differentiate between pelvi-abdominal and abdominal and pure abdominal mass. To differentiate pelvi-abdominal from purely abdominal swelling, this is done abdominally by trying to get below the lower border of the mass. If the lower border is reachable, it is purely abdominal, and it is not reachable, it is pelvi-abdominal. How to differentiate large ovarian cysts from ascites. This is done by doing shifting dullness. In ascites, shifting dullness is positive, while in ovarian cyst, dullness is constantly central with absent dullness on the flanks when the patient turns it on her side by shifting dullness. How to differentiate uterine from adnexal mass. During a bimanual examination, the criteria of the mass are identified according to those listed in this table. If the position of the mass is central, it is usually uterine. If it is lateral, it is usually adnexal. If the cervical motion is transmitted to the mass, it is uterine. Not transmitted, it is usually adnexal. If there is a sulcus between the mass and uterus, the mass is adnexal. If the consistency is mostly solid, the mass is uterine. If it is cystic or solid or mixed consistency, it may be adnexal. And so we differentiate according to these criteria: position of the mass, cervical motion, transmit or not to the mass, sulcus between the mass and uterus, and consistency of the mass during the bimanual examination. Using a fluctuation test in gynecology examination. Fluctuation tests are performed to determine cystic consistency of a mass. In large masses more than 5 cm, sorry, we perform double fluctuation test by pressing one pole of the mass by one index and receive fluctuation by the other index at the opposite pole. In small masses less than 5 cm, this is done by grasping the mass in between the index and thumb of the left hand and pressing at the center of the mass by the index hand of the right hand, index finger of the right hand. Fluctuation will be perceived by the index and thumb of the left hand in small masses if the mass is cystic. Source and characters of normal vaginal discharge. Vulva is one source from the greater vestibular glands, Bartholin gland and vulvar skin glands. The vagina may give a source for the normal vaginal discharge. However, there is no mucosal glands in the vagina. The vaginal secretion is transudation from the tissues and capillary of the mature vagina. In addition, there are desquamated epithelial cells which liberate glycogen, upon which the lactobacilli act, converting the glycogen into lactic acid. The cervix is alkaline mucus discharge, which is estrogen dependent, so it becomes copious and watery during the ovulation due to high estrogen, serum estrogen level. It is rich in sodium chloride, thus it burns under the microscope when dried on a glass slide and seen under the microscope. The uterine glands also discharge into the vagina, what's called uterine milk. Criteria of normal vaginal discharge. The normal discharge is scanty volume. The need to wear a pad or tampon continuously suggests excessive vaginal discharge. So, the normal vaginal discharge does not need to wear a pad or tampon. The color is usually whitish, usually characteristic odor resulting from the action of the bacteria on the apocrine 6 glands, not associated with itching or excessive burning of the skin. What are the differential diagnoses of abnormal vaginal discharge? Abnormal vaginal discharge may be monilial, may be trichomonal discharge, may be purulent vaginal discharge due to bacterial vaginosis, or purulent due to cervical infections, may be urine in zygovaginal fistulas, may be amniotic fluid in cases of pregnancy. What are the differential diagnoses of diffuse abdominal enlargement? Diffuse abdominal enlargement are due to 6F: fetus, fluid, flatus, fat, or feces. Fetus if pregnancy, fluid in ascites or cyst, flatus in abdominal distension, fat in obesity, feces in intestinal obstruction or chronic constipation, and lastly fibroid or other abdominal tumors. What are differential diagnosis of pelvi-abdominal mass? This diagram or picture simplifies remembering or facilitate remembering of the causes. The cause may be in the genital tract causes, or extragenital, maybe genital or extragenital. Genital includes uterine causes, cervical causes, ovarian causes, vaginal causes. Uterine as fibroid, endometrial carcinoma or sarcoma, cervical fibroid or malignancy. Vaginal may be hematocolpus, ovarian mass, which is considered as pelvi-abdominal when the hair, its lower border is not filled, and so it should be impacted in the cul-de-sac to be diagnosed as pelvi-abdominal. Extragenital bladder, full bladder or full all bladder masses, rectum, full rectum or rectal masses, peritoneal masses, or intraperitoneal fluid such as hematocolpus or pelvic abscess, and these are all extra genital causes of pelvic-abdominal swelling. Mention the causes of symmetrically enlarged uterus. The symmetrical causes of symmetrically enlarged uterus include pregnancy, fibroid if it is intramural or submucous, adenomyosis if diffuse type, subinvolution of the uterus, myometrial hyperplasia, previously called metropecia hemorrhagica, hematometria, biometria or physiometria. Physiometria meaning the uterus is tended with gases from gas-forming organisms as Clostridia bolshae, uterine malignancy as endometrial carcinoma, uterine sarcoma or choriocarcinoma. What are the causes of asymmetrical enlarged uterus? Causes of asymmetrical enlarged uterus include pregnancy when it is whether normal, abnormal, vesicular, or ectopic, fibroid. No. This is the symmetrical. This is cause of symmetrical enlarged uterus. These are the causes of symmetrically enlarged uterus. Asymmetrical enlarged uterus, fibroid, subserous fibroids cause asymmetrical enlarged uterus. Non-communicating hole, hematometria, non-communicating hole cause asymmetrical enlarged uterus. Hematosalpinx cause asymmetrical tube ovarian abscess may cause asymmetrical enlarged uterus. When attached to the uterus. Mention differential length of cervical enlargement, congenital hypertrophy, or elongation of the portion vaginalis, granulomatous lesions such as syphilitic gamma TB, bilharziasis, or amebiasis, or actinomycosis, chronic cervicitis, including endocervicitis, interstitial cervicitis, cervical erosion, Nabothean follicles, mucus polypi, and cervical ectropion, cervical ectopic pregnancy, and cervical abortion. How to differentiate between those? By observing the internal os. If it is closed, it is cervical ectopic pregnancy. It is opened, it is cervical abortion, a part of a subtype of inevitable abortion. Cervical polypi, whether true or false, polypi, corporeal polypi passing through via the cervix. How to differentiate? By uterine sound, trying to rotate the uterine sound around the pedicle of the polyp. If it rotates 360 degrees, it is uterine. If not, it is cervical. cervical endometriosis, which is rare, cervical neoplasm, benign or as fibroid or malignant as carcinoma. What is the differential diagnosis of vulval swelling? This table will summarize that differential diagnosis of vulval swelling, vaginal swelling, cystic swelling or and solid swelling. Cystic as Gardner cyst, which is a vestigial remnant. Hymenal cyst, endometriotic cyst, vaginis emphysema, implantation cyst as dermoid, pseudo cyst, cystocele, rectocele, enterocele, and so on. And solid vaginal swelling such as fibroma, neurofibroma, organized hematomas, vaginal cancer, and foreign body granuloma. Differential diagnosis of vulval swelling. It is divided mainly classically divided into swelling of non-vulvar origin appearing at the vulva and swelling of vulvar origin. We start with swelling appearing at the vulva with non-vulvar origin as anterior wall vagina as cervical, cystocele, Gardner cyst, urethral diverticulum, and urethral caruncle, posterior vaginal wall, rectocele, and enterocele, vaginal vault prolapse, and cervical congenital elongation of the portion urinalis and second degree uterine descent, cervical polyps. The third degree of uterine descent, uterine inversion, and pedunculated corporeal fibroid. And these are the non-vulvar origin appearing at mass of non-vulvar origin appearing at the vulva, and lastly the round ligaments and inguinal canal, hydrocele of the canal of neck, which appears at the mons veneris. Vulval swelling vulval origin as Bartholin cyst, sebaceous cyst, endometriotic cyst, hymenal cyst, and clitoral cyst or implantation cyst, traumatic vulvar hematoma, inflammatory cyst, neoplastic swelling, vascular swelling as vulvar edema, vulvar varicosities, and vulvar elephantiasis. Congenital cyst as congenital atrophy of the clitoris, and congenital hypertrophy of the clitoris, and congenital hypertrophy of the labia minora. Differential diagnosis of masses appear at the cul-de-sac. Genital causes such as RVF, uterus, posterior uterine wall fibroid, and posterior cervical fibroid. These are all uterine causes. Tubal either has a hydrosalpinx or ectopic pregnancy, hematosalpinx, hydrosalpinx, or pyosalpinx. Ovarian as prolapsed ovary cause deep dyspareunia, non-neoplastic ovarian swelling, and small-sized ovarian neoplasm. Extragenital causes of mass in the cul-de-sac include pelvic hematocele, pelvic abscess, pelvic tuberculosis or tuberculous peritonitis, pelvic endometriosis, metastatic implants from ovarian cancer. Rectal causes impacted fecal matter or cancer rectum. Retroperitoneal causes as pelvic kidney, and retroperitoneal tumors as sarcoma or lymphoma. Tumors of pelvic bones. We stop here to facilitate uploading the video, and we start in the next video presentation from slide 48. Thank you till now.